All right, welcome back, everybody. This is going to be Chapter 14, Anti-epileptic Drugs. All right. So I'm Nurse Nick. I'm also the Pharm 1, Pharm 2 instructor, AHA, BLS, ACLS, PALS, certified instructor, all of those things, emergency department nurse. Got a lot of nursing experience. So Chapter 14 is going to be anti-epileptic drugs. I don't want you to, when you read anti-epileptic on the very first slide, there's also anti-lipemic drugs. It's not the same thing. Anti-lipemic drugs are for lipids and for cholesterol, right? And also analeptic, and analeptic goes more with CNS stimulants. So anti-epileptic drugs be given to treat like epilepsy. What do you all know about epilepsy? Anybody? Epilepsy is when your patient's probably going to have a seizure disorder. So let's talk about that more. All right. So epilepsy is a syndrome of the CNS dysfunction, so your central nervous system dysfunction. Most common chronic neurologic illness results from excessive electrical activity of neurons located in superficial areas of the brain and your gray matter. So it's too much CNS stimulation, and it can lead to a seizure. All right. So when you have patients that have epilepsy, what do you think some good considerations are for them? Right? They should probably not go to raves or parties or something, right? They shouldn't be going to concerts with a whole bunch of flickering lights or a lot of stimulation. They're going to be triggered by too much CNS stimulation. So you should reduce stimulants and exposure to excessive stimulants like that. So epilepsy, this following terms are often used interchangeably, but they do not have the same meaning. So seizure is going to be a brief episode of abnormal electrical activity in nerves of the brain. A convulsion is the involuntary spasmodic contractions of any or all voluntary muscles throughout the body, including skeletal muscle, facial muscle, or ocular muscle. And then epilepsy is the chronic recurrent pattern of seizures. So somebody that consistently has patterns. Seizure is going to be an isolated event, and a convulsion can also be, your patient can be lucid, right? And just to talk about that for a second while we're just talking about seizures, you all should also know the interventions for seizures that go along with this. I know this isn't a med-surg class, but while we're talking about it, epilepsy is going to be the condition of regular seizures that exist. And then you can have seizures or convulsions. So your patient, some of them actually have seizure disorders, and they'll know that it's coming on. I took care of a patient in the emergency department young in my career. It was probably like 8 or 9 years ago. It was about 4 o'clock in the morning, working third shift, going through school, and the whole emergency department was pretty empty. There was probably just a couple patients, and this was like a 20-year-old girl in here, and she had her grandma with her. So we're at the nurse station, throwing paper balls or doing professional things that we're supposed to do at the nurse station. And then all of a sudden you hear grandma go, woo! Right? She made this real crazy noise like that, right? And everybody's like, uh-oh, we should all get up. So we all went into the room, and actively in that patient's room, she was having a seizure. So this is probably early 20s or, high teenager, 20-year-old female. And she's actively convulsing everything in bed, and she's literally biting down on her tongue, and almost half of her tongue is just hanging out. She didn't completely bite it off. There's just blood, coming down. I know that's a graphic scene, but what you need to consider is we're going to be giving these medications. You need to understand the circumstances that exist sometimes when you give these medications. This is a visual. A seizure is when an involuntary contraction just tightens everything up. This patient is not able to breathe, and she's biting her tongue off, and she's staring at you. You know what I mean? Like, it's just terrible. So in this section, while we're talking about anti-epileptics, we're going to talk about medications we're going to give to prevent these seizures for people that have chronic seizures, right? And then also, what are we going to give for epileptic patients that are having an acute attack, right? They're having an acute attack. In that case, anybody know what we're going to give? We're going to give Ativan generally. We're going to give benzodiazepine. If we're talking about benzodiazepines, what do you all know is the reverse of the antagonist, the antidote for a benzodiazepine overdose. It's going to be romazicon or fluazanil. We got to remember those previous chapters, guys. We got to build on the knowledge that we have without getting rid of that. Antidotes are huge in pharmacology. They're going to be highly tested. They'll show up on your NCLEX. And I'm here to prepare you for your boards, right? This is why we come to school. It's why we come to class. So this chapter, again, over anti-epileptics, we just discussed the definition of epilepsy, seizures, convulsions, things like that. Epilepsy, you can have primary or secondary, and then they throw these big words in here like idiopathic. I had a respiratory therapist in Covington ER tell me, he said, idiopathic just means the idiots can't figure out where it came from. Idiopathic, by definition, means unknown origin. They don't know why this patient has epilepsy or what's going on in their central nervous system that's causing extra excitation to cause seizures, right? They just know that it exists. Now, you can have secondary, which secondary is symptomatic, right? This is why we watch for people that have very, very high fevers, because you can have a febrile seizure, right? So it can come from trauma, can come from infection, fever, cerebrovascular disorder, and also febrile in young children. But I'm going to tell you, young children generally sustain fevers much higher than adults do. So status epilepticus, this is multiple seizures occur with no recovery between them. This is very, very risky. And when you have somebody having a seizure, just like that girl, what would we have done? We probably would have set her back a little bit. Hers was kind of more specific because she's bleeding out her mouth. But with seizures, anybody at risk for seizures, if you're taking care of them, if they're coming and say, I have a seizure disorder, I've had risk for seizures, I've not been taking benzodiazepines, because you know from the CNS depressant chapter, if you stop taking benzos, you're at risk for seizures. So that medication is there, that patient is there for a med refill, right? We do padding. You need to do bed padding, right? We call them seizure pads. Patients that you're taking care of need to have seizure pads if they're at risk for having a seizure. But when they actively have a seizure, this patient's safe in bed. If they were standing, we would probably lower them to a lying position, and we would want to try to hold them up on their side to reduce the risk for aspiration. So if she's got blood in her mouth or whatever, she's puking, never stick something in anybody's mouth that's having a seizure. You don't want to. You'll lose a finger, you'll lose whatever. It's going to get stuck in your mouth, go in the airway, whatever it's going to be. So those are some things for seizure. Again, it's not med-surg, but it's all relatable, guys. All of this is relatable. Pharm and med-surg, just... So status epilepticus, multiple seizures without happen. And if you have multiple seizures, what's the risk for the patient, right? They're not breathing. They're going to have hypoxia, right? They're going to have a lack of oxygen goes to their brain. That's why post-seizure, we're going to give them medication to stop the seizure, like a benzodiazepine, but we're going to put oxygen on them. We're going to hyperoxygenate them. It's a true medical emergency. So, anti-epileptic drugs. It says here in red. Everything in red is my new highlight for these PowerPoints that I made. I'm trying to change it up, make it more interesting. AEDs, anti-epileptic drugs. If they're talking about seizure medications, they're talking about AEDs. But really, in the healthcare context, AEDs are the defibrillator devices, right? The AEDs. So don't get them confused or anything like that. But it might show up on your test. That's why I'm making a point of it. So anti-epileptic drugs are also known as anticonvulsants. All right. So we already know that seizure activity is a result of too much CNS what? Stimulation. So if they have excessive CNS stimulation, some of these drugs are probably going to be CNS depressants, right? Whoa, we're probably going to hear some drugs that we already know. Cool, good with that. Goals of therapy with these drugs. What's the therapeutic outcome? To control or prevent seizures while maintaining a reasonable quality of life, to minimize adverse effects that are drug-induced toxicity, and also anti-epileptic drugs therapy is usually lifelong. If people have seizure disorders, they're generally going to be on these medications the rest of their lives. A combination of drugs may be used, but that's going to be up to the physician. You can see one or drug, you can see two drugs, whatever it's going to be. Single drug therapy is started before multi-drug therapy is used. That's obvious, right? What did we learn about when we started medications with absorption, metabolism, age-related stuff? Low and slow, one at a time. And then you can jump into adjuvant therapy or combination therapy. Some of these drugs may have serum drug concentrations must be measured. Okay, so I'm going to go ahead and start saying drug names. PHENYTOIN or DILANTIN is an anti-seizure drug. DILANTIN has a narrow therapeutic index. We talked about narrow therapeutic index in the previous chapters. It's not going away either. PHENYTOIN, vancomycin, lithium, all of these have narrow therapeutic indexes. And what does that mean? In the most basic sense, it means it's, as a nurse, it's a test that I got to pay attention to, right? That's what it means. But if somebody's on PHENYTOIN or DILANTIN, a narrow therapeutic index, right, the DILANTIN level is going to be between 10 and 20, which we'll go over that later. There should be circulating enough circulation medication to be above 10 so it's actually effective. Because if you don't hit 10, it's not therapeutic. It's not working. We need to increase the dosage. If it's above 20, then there's too much, right? There's too much medication, and it can cause contraindication, adverse effects. Depending on what drug it is, right? It could cause what drugs generally affect one of two organs. What are they? Your liver or your kidney, right? So it could affect your liver, cause hepatotoxicity, or it could be it cause renal function, which you want to look at your creatinine, right? So a narrow therapeutic index is you need to have enough to make sure the drug works, but also you don't want it to be too high, so you reduce the risk for adverse effects. And if you're scheduled to give DILANTIN and you look at the drug level before you give it, and I said that a therapeutic index is between 10 and 20. If the blood draw we just did says that the result is 22, can we go ahead and give DILANTIN? Yeah, we're still good. Keep up the regimen. Keep doing what you're doing, right? Narrow therapeutic index. We need it. It's a drug that, as a nurse, I need to know I need to draw blood every once in a while. There's going to be orders in for it. And it's got to be between those certain levels to be effective or not be toxic. So here's some names of some medications in here. PHENYTOIN, PHENOBARBITAL. We talked about PHENOBARBITAL. PHENOBARBITAL was brought up when we talked about CNS depressants. So what do you think adverse effects of PHENOBARBITAL are? Respiratory depression, lethargia, all those things, right? Carbamazepine, levetiracetam. Levetiracetam is Keppra. You all heard of that. PRIMIDONE. All these correlate better with seizure control and toxicity than do those of valproic acid and clonazepam. So clonazepam, it's got a suffix of Pam, right? Your lambs and your Pams, crazy Aunt Pam. What kind of medication is clonazepam? It's a benzodiazepine. So benzodiazepines can actually be given in small doses to also reduce the risk for seizures. But generally, benzodiazepines like lorazepam and Ativan, which are the same thing, are going to be given when you have a what? When you have an acute attack. All right? Not all the time is that the case. You can still get benzos to prevent, but a lot of these other medications generally treat seizure disorders before those do. So moving on in our anti-epileptic chapter. Anti-epileptic drugs traditionally used to manage seizure disorders include barbiturates, which are your CNS depressants, like your phenobarbital, hydantoins, which is going to be your DILANTIN. That's one of the new ones that I've been talking about. And then also this other one with valproic acid. To be honest, valproic acid is given a little bit more. It does actually, I don't even want to say that. Valproic acid does treat seizure disorders quite a bit, but it can also be given for bipolar disorder as well. And then you can have second and third generation anti-epileptics. So mechanism of action and drug effects. The exact mechanism of action is not known. That's crazy, right? That's 2 or 3 chapters I've taught medications where that's frankly the truth. Especially since a lot of these CNS seizure disorders or epilepsy disorders, they're idiopathic too. What the idiopathic means? Unknown origin. We don't even know what causes it. So pharmacological effects, it reduces nerves' ability to be stimulated. So if epilepsy and seizures are a result of too much CNS stimulation, then these medications are going to suppress transmission of impulses. Doesn't that make sense? So decreased speed of nerve impulses. Decreased speed of nerve impulses, conduction with a neuron. And then I always remember back in A&P, like I still see the nerve fibers with the myelin sheath that's there, so the electric can jump, you know, down the pathway and stuff. I visually still see that going on when somebody's having a seizure. So anti-epileptic drugs indications. Why do we give anti-epileptic drugs? This is the indication. Why do we give them? It prevents or controls seizures. Boom, that makes sense. Long-term maintenance therapy for chronic recurring seizures. Acute treatment of convulsions and status epilepticus. An indication for these drugs is we can give it for acute treatment of a convulsions and status epilepticus. If somebody's actually having convulsions and status epilepticus, what drug did we say we're going to give for an acute attack? We said we're going to give lorazepam, which is Ativan, but we're definitely going to give a benzodiazepine, and benzodiazepines have the suffix of what? Your lambs and your Pams, your crazy Aunt Pam, right? And you remember somebody having a seizure, you keep them safe. What should we do? We're going to roll them up on them side, and when they stop having a seizure, we're going to hyperoxygenate. But while they're on their side having a seizure, this is when somebody's going to dilute some Ativan, put in some Ativan into their IV. And honestly, a lot of these people that are at risk for seizures, they also, I believe it's Valium that they have at home, which is another benzodiazepine, but they have rectal Valium. So if somebody's having a seizure, a family member can give them some rectal Valium. That's a real thing too. Or another rectal benzodiazepine. So anti-epileptic drugs, adverse effects. Numerous adverse effects come with these medications, and they're all a little bit different. You've learned about phenobarbital and barbiturates as a CNS depressant. So you already know the adverse effects with those, right? But I will say, adverse effects often necessitate change. There's black box warning as of 2008. So for PHENYTOIN or DILANTIN, this one can actually cause suicidal thoughts and suicidal behavior. You're going to learn there's a handful of medications that can kind of mess with you, like definitely antidepressants. Antidepressants takes 4 to 6 weeks to generally even start working, but in that interim, those also cause suicidal thoughts, behavior, ideation. All right. So anti-epileptic, we're talking about seizure drugs. What seizure drug are we talking about? I said Dilantin. You need to recognize this as PHENYTOIN, okay, because that's the word you're going to see. It can have a black box warning that says this might cause suicidal thoughts, okay? So long-term therapy with PHENYTOIN or Dilantin may cause gingival hyperplasia. Go ahead and pause this and Google images that. Are you back yet? Yeah. Yeah. It can cause problems with your mouth. So if you're taking this medication, what profession do you think we should consult? A dentist. Yes. This can also cause acne, hirsutism. What's hirsutism? Excessive hair, right? All these words keep popping up. I'm telling you, we're going to see it. It's not just Rogaine, right? And also Dilantin bases. Make sure you take care of extra care of your teeth, and then inform your dentist when you're actually taking this medication. Those are important considerations, right? So, anti-epileptic drug listings. Again, I've got highlighted AED because if you see AED in this chapter, it's referring to anti-epileptic drugs, and these are all drugs that are given to treat convulsions or seizures or epileptic episodes, right? So, valproic acid, boom, gabapentin's on here. What? Yeah, we've already talked about that with CNS depressants. Gabapentin, also known as Neurontin, is actually an anti-seizure drug. But what is it usually given for? Peripheral neuropathy. Because it works on what? Your CNS, your central nervous system. Is this like starting to mold things a little bit together with some of these thoughts and diagnosis and understanding? These drugs just work on your neurons and your nerves, right? Lamictal is another medication. Keppra, levetiracetam is given a lot. Topamax. I gotta say at least 5 of these medications on this list are regularly given for seizure disorders that I've seen in the emergency department on a regular basis. Also, Keppra, levetiracetam, I've given a decent amount IB in the ER and also in the ICU. So, barbiturates, phenobarbital and primidone. Primidone is metabolized in the liver to phenobarbital. This is most common adverse effect. Phenobarbital is a barbiturate that we talked about in the CNS depressant section. So it makes sense that the adverse effect is sedation, right? Therapeutic effects, this one does have drug levels that you can draw, which can be between 10 and 40. This medication isn't used as often, though. Barbiturates aren't used as often as other medications are. Contraindications, known drug allergy. We say that with every drug ever. We can't give the drug to a patient if you're allergic to barbiturates. You want some? No. Known drug allergy, don't give the medication. Liver or kidney impairment, respiratory illness. If you have respiratory illness, we shouldn't give you a CNS depressant. Adverse effects can be cardiovascular, CNS, GI, and dermatological reactions. Now we're going to talk about this next set of drugs, which is your HYDANTOINS. This is your PHENYTOIN or DILANTIN. This is one that's talked about. In general, with seizure medications, we talked a lot about seizures. We talked a lot about epilepsy or convulsions, anticonvulsants. We talked a lot about how it works, but we haven't talked a lot about medications because there's only 25 slides and there's not a lot of medications that you actually get. It's the regular ones like the levetiracetam, Keppra, Topamax, the ones that gabapentin, Neurontin that can also be given for seizures, but not really. All of these that control regular chronic and epilepsy diagnosis or anticonvulsants, and then the other medications if they're actively, acutely having a seizure, what are we going to give? Your benzodiazepines, right? So, PHENYTOIN or DILANTIN, we do need to remember this, has been used as a first-line drug for many years and is the prototypical drug that we give. Adverse effects are going to be gingival hyperplasia. You just Google image that. It's going to be important. Acne, hirsutism, which is increased hair, dilantin facies, and osteoporosis. Therapeutic drug levels are going to be 10 to 20. You do need to remember therapeutic drug levels for dilantin. It's got a narrow therapeutic index. It's between 10 and 20. It's the same as your bank level, right? You need to know your bank level. But it's also the same as your BUN. So your blood urea nitrogen, your BUN and your creatinine are your renal labs. Your BUN range is between 10 and 20. Now, don't remember numbers for everything. Just now I remember my BUN because you need to remember that. It's part of a BMP, basic metabolic panel. I've got all these labs at the end of this, okay? But you need to remember your PHENYTOIN or DILANTIN level is the same as your BUN. It's 10 to 20. You need to know the therapeutic index. You're going to have test questions that ask you if you understand what therapeutic index is and your medication levels. Narrow therapeutic index, this is going to be your safe and toxic plasma levels. I explained that quite a bit. With PHENYTOIN or DILANTIN, the IV doses need to be low and slow. When you get NCLEX or any questions related to PHENYTOIN or DILANTIN, it needs to be a slow drip. Sometimes it can be diluted or infused with normal saline. This medication does not go well with D5. But in pharmacy in general, IV medications generally do not get mixed well with D5, which is dextrose 5%, right? Because it can cause interactions. But sometimes the dextrose in there helps the absorption or binding of some of those drugs. So like antibiotics will have dextrose in it, things like that. So D5 does come in some drugs, but as a rule of thumb, it usually interferes with everything, right? D5, D10, whatever it is. I got sidetracked. PHENYTOIN DILANTIN, it's an anti-epileptic seizure medication. The IV dose should be given low, slow. You never want to give more than 50 milligrams a minute. That's not really anything that you have to remember. It's helpful if you start remembering small details. But it needs to be given slower because it can cause hypotension. All right, so you want to look out for that. IV drug administration, slow IV directly into a large vein through a large gauge, 20 gauge or larger. What number is bigger than a 20 gauge? What's the next gauge size you would get if you're putting an IV that's bigger, a larger, fatter bore, bigger lumen than 20 gauge? It would be an 18 gauge. It's like your ears, okay? The smaller the number, the bigger the gauge. It can be diluted in normal saline for infusion. With phenytoin or dilantin, this is a medication that you have to use an inline filter. All right, another one's going to be like amiodarone, or there's a few of them. But phenytoin dilantin, give it low and slow, mixed with saline through a filter with a saline flush. Anytime you give any medication, after you infuse it, you always flush the IV site so the medication doesn't sit in there. We all know that. So the next medication is a carbamazepine. This medication pops up quite a bit on some of your tests. Carbamazepine, or known as Tegretol. In general, if you were taking a comprehensive pharmacology test and you just need to recognize carbamazepine, you pretty much, when it comes up, you just need to recognize it's an anti-seizure medication, to be honest with you. But this is the second most commonly prescribed anti-epileptic drug in the United States after Dilantin. Gabapentin or Neurontin, this is going to be, it can treat seizures, but this medication primarily treats what? Gabapentin or Neurontin is primarily given for peripheral neuropathy. What diagnosis is generally associated with peripheral neuropathy? Diabetes, diabetic generated peripheral neuropathy. So chemical analog of GABA, neurotransmitter that inhibits brain activity, so it slows things down because seizure activity speeds things up. It's believed to work in increasing the synthesis or synaptic accumulation of GABA. It treatment given for treatment of partial seizures, but most often used for neuropathy. Contraindications, don't give it if they're allergic to it. And then adverse effects can be CNS and GI symptoms. Levetiracetam, I talked about this. This is where you're looking at names and remember it. Levetiracetam is Keppra. This is a seizure medication. This can be adjunct therapy for partial seizures or without secondary generalization. Sometimes it's given adjunctively. If somebody's got risk for or previously just had a seizure, they might give Keppra while you're in the ICU or the ER acutely, where you're not really taking as much anymore. Mechanism of action, nobody knows. It just works. Adverse effects is generally well tolerated. There's not really any drug interactions that happen with Keppra or levetiracetam. Lyrica can also be given for seizure disorders. Where do you all hear Lyrica given for the most? In my experience, Lyrica is usually given for pain from fibromyalgia, which is a nerve pain, right? So it's a Scheduled 4 controlled substance, pregabalin, which is Lyrica. You need to remember the pregabalin. Schedule 4 substance, indication, adjunct therapy for partial seizures. Most commonly given for neuropathic pain, postherpetic neuralgia, and I don't know. Google it, okay? And fibromyalgia, right? Contraindications, known drug allergies, primary CNS related. And then valproic acid, we talked about this one. This one treats generalized seizures, but it also treats bipolar disorder. We're going to see this when we talk about our psych meds. And controls partial seizures, highly protein bound. Adverse effects of this medication with valproic acid are going to be the drowsiness, GI disturbances, tremors. That's huge. Valproic acid, they always ask for somnolence and then also tremors. But this medication may cause hair loss and hepatotoxicity and pancreatitis. You need to keep an eye on your liver enzymes with this medication. And it does have oral and injectable forms. Nursing implications of anti-epileptic drugs, oral drugs, take regularly in the same time every day. So let's think about this. Your patient has some of these medications like phenytoin or dilantin that require a narrow therapeutic index. Don't give up on me. I know it's a long lecture. Stick with me. Narrow therapeutic index seizure drugs. All right? So the point I'm making is patient education. When this patient goes home and they're taking these chronic medications because they're generally on the rest of their life, they should take them the same time every day. Why? So they keep a normal, regular therapeutic index. So if little Timmy wants to take his medication at 9 or 10 o'clock in the morning, or however the doctor prescribes it, that's fine. But if he takes it on Monday at 9 o'clock in the morning, and then Tuesday at 5 in the afternoon, and then Wednesday at some, oh, I forgot, it's like right before I went to bed, let's go ahead and do it at 10 o'clock at night, his levels are going to be jumping around. Seizure medications, these patients need to take these medications at the same time every day to keep a consistent therapeutic level in their bloodstream. That's why it's important. All right. Now, what did I say about seizure medications? If we stop seizure medications, what do you think your patient's at risk for? Probably having a seizure, right? Doesn't that make sense? Good. So with seizure medications, make sure you take it at the same time every day. But if you're in the hospital, your patient's going to have, oh wait, little Timmy's got cholecystitis. What's cholecystitis? Chole is gallbladder. Itis is inflammation. Little Timmy's got inflammation in his gallbladder. He's going to have a cholecystectomy, ectomy, removal. Okay. What do you know about before surgery? Timmy at midnight the night before is NPO, right? Surgery is going to be 2 o'clock in the afternoon next day. So he's NPO. He's not going to be able to take his PO anti-seizure medication. And what's ordered on the chart for you as the nurse is a PO seizure medication. You'll be like, what are we going to do here? He's NPO. He's supposed to go he's supposed to go to surgery at 2 p.m. It's 10 o'clock in the morning, his schedule, whatever time. What should we do for this patient with it on the MAR saying a PO medication? We call the doctor. You remember that chapter? If the orders are questionable, we should always call the physician. Bring those chapters back. Don't lose that. All right? Call the physician. We need to give him a different route of administration. He needs his medication. Right? So the next question, here's a practice question. A patient with unstable epilepsy is receiving IV doses of PHENYTOIN or DILANTIN. The latest drug level is 12. Which administration technique will the nurse use? The answer is going to be B. Infuse slowly, not to exceed 50 milligrams per minute, right? His therapeutic level is within normal range. Just keep giving him the medication. Everything's good, right? Administer the drug by rapid IV push? No. One, the range is 10 to 20. He don't need rapid anything. He's already therapeutic. It doesn't matter. But we don't give this drug rapid IV. It's always slow. Rapid IV can cause hypotension. Remember that? Mix the medication with dextrose? Nope. And then administer via continuous infusion. It's not going to be continuous, right? If he has an actual infusion of levetiracetam, caprin, dilantin, phenytoin, he'll get the dose over whatever the doctor says, an hour or 2 hours, 30 minutes, whatever it's going to be, and then it'll be stopped. It will not be a continuous infusion, right? So IV forms, intravenous forms, follow the manufacturer's recommendations. Delivery should be low and slow. Low dosage, slow, no more than 50 milligrams a minute. Monitor vital signs during administration. What are we going to monitor during administration? Hypotension, right? Avoid extravasation of fluids. What is extravasation? What is an infiltration? What's the difference? So an infiltration is when you got an IV going into your vein, like normal saline, and your vein blows and it infiltrates. You got normal saline floating around your adipose in your tissues underneath your skin. under your dermal layer or whatever. That's an infiltration if it's normal saline. An extravasation is that fluid is extra. It's going outside your vessels and it's a vesicant. And if it's a vesicant, who should we call? We need to immediately call the pharmacy so we can get the antidote. Eventually you'll let the doctor know and all that stuff too, right? Use only normal saline with phenytoin or dilantin. Excuse me. So nursing implications of anti-epileptic drugs. Teach the patient to keep a journal to monitor. You know, are the medications effective? When did I have seizures? Response to AED. How well did they respond to the anti-epileptic drug medications? When did they have seizures? When did they have adverse effects? Instruct the patient to wear an alert tag or ID. This is huge. A lot of people have bracelets. Some people even get stuff tattooed on them. Why is that important? Maybe they're unconscious and paramedics need to get them, right? Diabetics wear that stuff too. There's a lot of diagnoses that wear that. Even people that had a history of MIs or whatever, like all of those things exist. AEDs, anti-epileptic drugs, should not be discontinued abruptly. They may cause what? A withdrawal seizure. Somebody that's having an active acute seizure or convulsions, give that benzodiazepine. Most often, in my experience, it's always been Ativan, but I'm going to tell you other benzos can be given, like Valium. And then remember those other anti-epileptic drugs we talked about. Carbamazepine, that's Tegretol, or valproic acid, that's Depakote. Valproic acid is the one with the tremors. And follow driving recommendations. What do you think the recommendation is if your patient has seizures? Probably that they shouldn't drive. Teach patients that their therapy is long-term and possibly lifelong. Anti-epileptic drugs are not going to give a cure. They're just going to be treatment to decrease the onset of seizures. Monitor for therapeutic effect. What's the therapeutic of anti-epileptic drugs? Your patient won't have a seizure. Monitor for adverse effects, which are going to be mental status changes, mood changes, because we know PHENYTOIN or DILANTIN has a black box warning for high risk for what? Suicidal thoughts, ideation, actions, blah, blah. Changes in level of consciousness or sensorium, eye problems, visual disturbances, sore throat, fever, blood dyscrasia may occur with PHENYTOIN or DILANTIN, which is kind of like thickening of your blood is all you need to know. All right, so labs. If I haven't beat you guys up with labs yet, you need to know labs. When we talk about electrolytes, you all have already done a fluid and electrolyte chapter in Med-Surg, so you should know your BMP, which is your basic metabolic panel. I want you to know these labs. These labs for my test going forward, and actually any class going forward, really, they're going to be up for grabs for knowing these labs. It's time to pick one and sit and memorize it, all right? Basic metabolic panel are your electrolytes. Your electrolytes are responsible for telling us a lot about your hydration status. There's different risks that are associated, right? MAG levels are going to be caused like, decreased tendon reflexes. Your calcium levels, if it's low, higher risk for tetany and kind of muscle twitching, things like that. Potassium is going to have higher risk for dysrhythmias. Sodium is going to have higher, more information for recognizing like fluid volume excess, deficits, and things like that. But your BMP is so important for you guys to know, right? So your sodium level, and another thing that goes along with these labs, and the NCSBN, the people that do the NCLEX testing, lab results are kind of different everywhere. They're variable, right? For my classes, I want you to know these, right? It's consistent with the curriculum throughout all of our school. So sodium levels, I think your book actually says 136 to 145. I just want you to remember 135 to 145. It's a nice round number. Also, 135 to 45, like 35 to 45 is going to be your 7.35, 7.45. That's your pH. And then also it's your CO2 level, 35 to 45. 35 to 45 is everywhere. Sodium is 135 to 145. So bring down that 3.5. Potassium is 3.5 to 5. But potassium is also the same as your albumin level if you can get that in. Calcium is going to be 9 to 10.5. Mag. So your book says 1.3 to 2.1. I actually tell my students remember 1.2 to 2.1 because if you can remember 1.2, you can just flip it. And then it's 2.1. Your phosphorus is 3 to 4.5. I say phosphorus starts with a P, so it's close to your potassium, right? If you can't even remember anything, like if everybody always remembers a potassium level is 3.5 to 5. Nobody remembers phosphorus. Phosphorus starts with a P, so it's close to your potassium. Maybe that'll help you on an NCLEX question somewhere, I don't know. But I know these are hard to remember. And then chloride is going to be 98 to 106. But the two things that are on your BMP, actually your glucose comes on your BMP as well. So I'm sorry that's omitted. But your renal labs, your BUN and your creatinine, while we're talking about this, your BUN is your blood urea nitrogen. It's 10 to 20. This is the same as your phenytoin or dilantin level. You need to start remember that because 10 to 20 is a narrow therapeutic index for dilantin, which is the whole reason why I'm having this conversation and talking about these labs. Because if you knew all your lab ranges, I would say you need to remember phenytoin is the same as what? Your BUN. And that range is 10 to 20. So the next one's your creatinine level. Your creatinine level is 0.6 to 1.2. And actually, your lithium level is close to that. So I always tell my students when we teach you about lithium, bipolar, and psych drugs, I tell you, remember, lithium is the same as creatinine. Please study this slide. Please know your BMP. You have to know your phenytoin dilantin level. And you need to know these electrolyte levels, BUN and creatinine. You have to know them for your test. All right? And they are going to be testable for every single one of my tests going forward. You need to remember your basic metabolic panel is your electrolytes, and remember all these numbers. All right, so that's everything from the Lilly book, from your textbook. Here's the reference page for that. If you all have any questions, please message with me. Thank you for sticking around. Let me know if you like the video. Let me know if you hate it, whatever. I don't care. I take constructive criticism. Like, follow, leave a comment, something like that. Thank you.